I'm so excited to have been invited here to speak, and I'm so glad to see such a turnout. And also, what I learned in preparing for this lecture about the group is that there already is, it's kind of, there's some trans fluency among the general audience too. And so what's really exciting is that we can kind of dive into a little more than the kind of, there's a lot of Trans 101 lectures that get given because there's just so little information out there. But it's really exciting to have an opportunity to kind of dive into some more depth. And so the topics that I'll try to blast through in the next 42 minutes, just a brief background on some epidemiology of why is HIV such an issue in transgender populations, some thoughts about ways to engage transgender people in HIV, both biomedical prevention and treatment, and I'll show you a little bit of data too. And then we will go into some more details about hormone management of transgender women with a particular focus on some comorbidities and complicated coexisting conditions. And I'll also briefly talk about interactions with antiretrovirals. The reason I'll only talk about it briefly is because there's really not much to say about it. So just to set the stage, HIV is a big deal in transgender populations, particularly transgender women. So this is a meta-analysis that was published a couple of years ago. And you can see here that in the US, the kind of estimated prevalence of HIV in transgender women is 21.7%, so odds ratio of 34.2. And actually in the US, we have a higher estimated prevalence than a pooled worldwide estimate. So we're really not doing, the confidence intervals overlap, but we're really not doing very well here in the US compared to the rest of the world. And so let's talk about some of the different factors that drive this, that both drive the HIV risks as well as outcomes in people who are infected with HIV who are transgender. All of these different kind of determinants and predictors and barriers. So transgender people experience discrimination. There are different studies, you look at them, anywhere between 1 in 5 to 1 in 2 or 3 transgender people say that they have put off going to the doctor because of actual or perceived discrimination that they've experienced in the past. They may have experienced dealing with emotional trauma, physical trauma, PTSD. There's actually data showing that 1% of transgender people report being physically assaulted in a doctor's office. So, these kinds of things happen, or they get assaulted in the waiting room. They try to go to the bathroom and then there's somebody who's not comfortable with that and then they get assaulted in the parking lot. A lot of other things that just generally predict poorer health in general, unstable housing. So a real big problem we have is that in this country currently, if you live in one of 32 states, you can be fired for being transgender. So you can be fired because you're late, or you can be fired because you used profanity with a client. You can be fired because you're transgender, and that's totally grounds for dismissal. And until that goes to the US Supreme Court and federal protections are enacted, there's no grounds. And then you're thinking about people coming from other countries. There's lack of legal protections. I mean, in some states, you can't even get your driver's license updated to reflect your identity. So you live in Ohio, you can't get your driver's license changed, and there's no workplace protection. So you look like a woman, but you're applying for a job with the name John, and then you show up because you can't get your legal name changed, and then you show up for your job interview, and then you don't get a job. And so then people are driven into kind of this shadow economy, sex work, a lot of the constant discrimination results in behavioral and mood issues, substance abuse becomes an issue, and all of these things become feed forward. So transgender men, we actually know very little. There have only been a couple of kind of very focused brief studies that are showing we don't really know if there's a risk in transgender men that's higher than non-transgender men who have sex with men. There's so many questions that are unanswered. But the important thing to know is that transgender men may have sex with men. There are transgender men who have sex with men. They may be having anal sex. They may be having vaginal sex. And we just don't have enough research. And we don't know why we're not seeing HIV pop up in the trans male community. We don't know if we're not asking the right questions or the right people. or maybe transgender men have a different capacity to negotiate a safe condom use or other agency in sex safety. Transgender women who are sex workers who are paying their rent based on how much they earn from their sex work are telling us that they're paid more if they don't use a condom. So there's an immediate direct link to HIV risk. So we do have data showing that transgender women are less likely to be taking their antiretroviral medication than a general population. This is from a clinic in New York from a few years ago. And so there's a bunch of different reasons why we think that is the case. And it has to do with a lot of the things I talked about, which prevent people from accessing care. It also has to do with, are we creating an appropriate environment? You know, first of all, are we taking a sexual health history? So this is kind of getting back to, are we asking the right questions of transgender men? We need to assess risk in a way that's actually meaningful to the patients, right? So if you just say, do you have sex, right, that doesn't really tell you much. And when you get into trans populations, some people have penises, some people have vaginas, all people with penises aren't men, all people with vaginas aren't women. We need to know what's going where. You know, if you have sex with men, but you're only having sex with transgender men and none of them have had phalloplasty and you're not having any receptive penile sex, your risk profile is different. If you only have sex with women, you're a transgender man, you only have sex with women, but all the women you have sex with have a penis and you're having receptive sex, well, then you have a different risk profile. So it's important to take these kind of anatomy specific, but also do it in a culturally appropriate. So this gets into the part of the reason about why transgender people maybe are taking their antiretrovirals less and they're not coming to the doctor. They feel they're not being treated in a culturally appropriate manner. So open-ended questions, non-judgmental, not projecting your experience from your prior trans patient onto your current trans patient. This trans patient may not want to hear that they look great. They may not be told that you couldn't even tell. Another patient may say to you, how do I look? Can you tell me how I look? They're very interested in your feedback and your affirmation, but other people don't. And all transgender people are different, just like everybody else. So cultural humility, approach each patient as an individual. So getting back to that reduced ART adherence, how can we engage transgender people into HIV programs and services? Unfortunately, historically, most of the research money and the dollars that have gone on both researching the interventions for linkage, for prevention, behavioral interventions, biomedical interventions, everything has been focused on MSM. And then you see the publication come out and it says, blah, 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 in MSM and transgender women. And then maybe you see a toolkit developed by the CDC or California State or New York Department of Health or whatever that's an adaptation of something for transgender women. But what we really need to do is build these from the ground up. Transgender women are not men. They go to get on the bus, and the bus shelter has an ad that shows two men, and they look really happy, and they're both taking their PrEP. That transgender woman is like, PrEP isn't for me. PrEP is for gay guys, and I'm not a gay guy. That's what they say. And so then the social marketing messaging is lost. Transgender women, we're doing a support, a med adherence group interventions for MSM and transgender women. But that doesn't really, transgender women are like, well, I don't want to go there. And actually, it's probably even more triggering than for if it was just like PrEP, ART intervention, adherence intervention for everybody. Because specifically, the trans women are like, I specifically do not want to go to a place where it's like men and transgender women because I don't identify as a man and it's going to feel very mannish to me to go there. So we need to do trans-inclusive social marketing. We have to really also, in addition to developing that trans-inclusive outreach, we have to really develop these interventions that are trans-oriented. But there are also community-level concerns. So we have to, the community is concerned about interactions between HIV medications and gender-affirming hormones, for example. So we have to develop information and materials and marketing and get messaging that is oriented towards trans people and not adapted. And then we really need to make sure that services are provided by a provider and by a clinic who's knowledgeable in transgender health, and I'll go through some of that data that we have. But this is from a qualitative study by my colleague, Dr. Jay Sevelius at the Center of Excellence for Transgender Health, who this is what trans people in an ART adherence intervention qualitative study, this is what they're telling us needs to happen for them to take their meds. Okay, So let's talk about PrEP in transgender women. So we recently published a sub-analysis of the IPREX trial, which I'm assuming everyone is familiar with, looking at the trans women within IPREX. If you look at the original IPREX data that came out in 2010 and then some of the additional papers that have come out of that database, a lot of it is trans women and MSM, right? It's kind of aggregated together again. So what we did, my colleagues at the Center of Excellence and then Bob Grant and Dave Glidden from the PrEP team, we spent close to a year poring through the database to really identify all of the trans people, because part of the problem is that they didn't collect gender identity data using the two-step method, which is what is your gender identity and what is your birth sex, and people who those two things aren't the same are transgender people. So there actually were a lot of transgender people missed on the initial assessment, especially because this was multinational with multiple languages, and there's all different terminologies. So we basically came up with criteria that included both identifying as trans or a woman or using certain feminizing hormones that we know or tend to be used by people for feminization. So we found 339 transgender women in the RCT arm of the study, in the initial RCT phase of the study. And there were a whole bunch of differences, all of which, a lot of them confer increased risk compared to the MSM in the study. So in the RCT, so IPREX was a randomized controlled trial, and then there was an open label extension phase. So in the RCT, there was no efficacy on an intention to treat basis in transgender women. So that means we basically look at people how they're randomized regardless of whether or not they're actually taking the medicine. But in the as treated arm, which means we actually look at who's actually taking their medicine, and that's verified by checking levels, none of the transgender women who seroconverted had protective drug levels at the time of detection. So the study was not powered to make any stronger statements than that, but this is really kind of interesting to note that transgender women tend to not be taking their medication, but when they do take it, it works. And then if you were transgender, you were less likely than an MSM to have always detected random drug levels, and that was statistically significant. In the open label extension, we found similar findings. While the PrEP uptake was similar to MSM, transgender women had overall less time with protective drug concentrations versus MSM. And transgender women, they trended towards having fewer concentrations that indicated more than 3 tablets a week compared to MSM. 4 tablets a week is kind of the magic number at which we think you're effectively protected. So further data from the open label extension. So trans women using hormones were less likely to have any or protective drug levels compared to transgender women who were not using hormones. So this is potentially raising a big flag that there could be a biomedical interaction between hormones and Truvada. But that's not backed up by the research that has been done on contraception and Truvada, which shows that there isn't any interaction. Now, the estrogen that's in contraception is different. It's ethinyl estradiol. It's a little bit of a different, it's modified chemically to have more stable pharmacokinetics to more reliably suppress ovulation. Don't tend to use that hormone as much in transgender. It's not recommended for use in transgender women, but a lot of transgender women use birth control because that's all they have access to. But in any case, that does raise a flag. And so if we don't think that there's science to support a biomedical interaction, then we have to think that there's some other kind of interacting variable. Pill burden, perception of interaction that's making people say, oh, well, I have to choose between one or the other. I'm going to choose my hormones. And we know that transgender women are more likely to say, if I have to choose between hormones or something else, I'm going to take the hormones. So just really alarming findings. There were only 2 seroconversions in the open label extension, and both of them had basically like undetectable drug levels. So not really powered to detect a lot, but what we did find, this is the hazard ratio relative to the blood levels of the medication, and then this is the actual blood levels of the medication. And if you notice, the red is trans women and the blue is MSM. It's basically the same. So on an as treated, when you actually measure people's levels, there's not necessarily an interaction. So something else is going on here. So this blue and purple, these are people taking hormones regardless of how they identified. So we had some people who identified as MSM, but they're taking hormones. And in some languages and cultures, people who in the US would be identified as trans identify as gay, but they live as women. And they basically have the same existence as a trans person. So we lumped them in with trans people. So hormone use, again, was a predictor of less likely to have protective levels. And so, again, one of the things we're going to do in our CHRP grant that was just awarded is we have a sub-study looking at doing a PK study. So we're going to actually check for actual interaction and try to figure out if this is behavioral, which is what we all think it is, or if it's relating to an actual interaction. So the last thing I'll show you here, trans women also are more likely to have either never or sometimes have detected drug levels if they're having condomless sex. So transgender women are less likely, basically they're less likely to be using PrEP when they need it the most. When they're the trans women who are having higher risk sex, but those who are having the higher risk sex are less likely to be using it. So let's talk a little bit more about interactions between hormones and antiretrovirals. So we know that trans women may prioritize hormone therapy over other aspects of health and healthcare, and that concerns over these interactions may lead to reduced adherence. So, and then I just kind of talked to you about those data. So, and then we talked about some other possible interactions that I mentioned earlier, things like possible pill burden, the effects of antiretrovirals on hormone levels. So we know there's no effect of the hormones on the antiretrovirals. We think that we're pretty certain to say that. But we do know that there are effects on the hormones from the antiretrovirals. Somebody starts taking a new antiretroviral, they start getting hot flashes or feel like their body shape is changing. They're not going to stop taking the hormones or just deal with it. They're going to say, I don't like this new, Complera, or what, they're going to chuck the HIV medications. So really important to kind of get more information together on that. And so that's what we're hoping to do. So, and then just to kind of prove it to you, I went into Hippocrates and I put in, 3 commonly used hormones, and then just for ease, I put in a, fixed combination drug that's commonly used, going back a couple of years when it was a little more commonly used. Even Hippocrates, and they're very conservative, right? They say everything interacts with everything. So we don't really think. So this is some preliminary data that's not really ready for prime time. This is from, I'm putting it up here. Hopefully this won't wind up plastered because it's not really ready to go yet, and the people at HRSA would probably be not super thrilled. But this is interim data that we presented at the NHPC National HIV Prevention Conference in Atlanta a couple of months ago. This is data from our SPINS initiative, which is 9 demonstration sites nationwide that are looking at interventions to improve linkage and retention in care of HIV-positive transgender women of color. This is doing exactly what I've been talking about, which is developing ground-up interventions designed specifically for transgender people. And then what we are doing here at UCSF is we are conducting the cross-site evaluation, and we're providing technical assistance to the sites too. So this is aggregate data from all 9 sites, so it doesn't divide down. This is not a cross-site evaluation. This is all 9 sites. And it's interim data, so it's not a full data set, and it hasn't been fully adjusted, and it is not a multivariate analysis. So this is preliminary only. But what we did is we came up with some different measures. So we looked at things like any use of hormones in the last 6 months you were strongly associated with any HIV primary care in the last 6 months. So obviously people who go to primary care and take medications. But you can see all of these interesting, important associations. Current hormone use associated with any HIV primary care in the last 6 months. These are not directional associations because it's a single point in time, so there's not like one predicts the other, it's just an association. But you can see, for example, if your viral load being undetectable, 3.25 odds ratio relating to hormone therapy from your current HIV provider. Whereas you're less likely to have an undetectable viral load if you're getting your hormones from a provider other than your HIV provider. So that's really, I think that's probably the most striking piece of data out of this. And then here's some more data. I don't want to get too much into this because I want to leave time for everything, but this is really important. If you have ever taken a larger dose of hormones than prescribed in the last 6 months, You think that antiretrovirals have a negative effect on hormones, odds ratio 2.88. So that's really playing into this, like, why aren't transgender people, are transgender people saying, I'm concerned about an interaction between my hormones and my antiretrovirals, and I'm going to try to compensate for that. One thing I'm going to do is take a higher dose, and maybe another thing they're going to do is just not take the antiretrovirals. So this is all stuff that we need to get more data on, and that's what we're hoping to do. And there'll be full multivariate analysis that will be reported on this in about 2 years, probably. I'm going to skip that for now. I don't know how important it is. I want to get into this stuff. So let's talk about hormones now, because I've talked so much about this. And our big hypothesis for our PrEP grant that was just funded, and what that's going to be is we have La Clinica, which is in Oakland, and then there's a clinic in Sacramento called the Sacramento Gender Health Center. They both will be providing co-located PrEP and gender-affirming hormones by a single provider and a single site. And our hypothesis is that this will improve uptake and adherence. SFDPH was also awarded under that grant, and they will be doing a similar but different intervention based at a couple of clinics here in the city, API Wellness and I think Tom Waddell. So why do we give people hormones? Well, there's actually a lot of supporting evidence. We know that hormone therapy reduces anxiety, depression, it improves social functioning and quality of life. And we also know that surgery has good impact on mental health. The regret rate is very low. The malpractice risk is effectively non-existent. The regret rate for a lot of other things we let people do in society is much higher than, like the 1% or less regret rate that exists for most gender-affirming interventions. So we know from other things like prenatal care that when you bundle a desired service with maybe a less desired service, that there may be synergistic benefits. And we, again, as I've shown you, we think that that will be the case with hormones. All of these procedures, including hormones, surgery, are all defined as medically necessary by the World Professional Association for Transgender Health. Those are the standards of care that you hear about. That's where like the letter writing for getting your surgery and all that comes from. The reason that they define it as medically necessary is because of all of this. Because these are just a sample of the many studies that have been done over the years that show improved outcomes. So as you'll see, we're going to talk a little bit about thromboembolic disease, for example, or other concerns associated with hormone therapy. Always should be weighed in the context of what are the benefits? If I'm going to significantly improve this person's social functioning and mental health, if I put them at slightly increased risk of A, B, or C, but then what are the benefits of this over here? And then you kind of say, okay, that kind of makes sense. Okay, this is actually the framework of gender affirmation that was developed by my colleague, Jay Sevelius, which, without getting into too much detail, basically describes the way that stigma associated with other external factors, psychological distress, social oppression, basically through an intermediary of decreased gender affirmation and a threat to gender identity, results in high-risk behavior. And then that is the ultimate outcome of that is HIV. Though you could argue that the ultimate outcome is lack of self-care, lack of access to going to the doctor, your A1C is 13 and you don't care. It's all applicable to anything. So all of these places that I've circled in red are ways to intervene in this model. When you give somebody gender-affirming treatment, you're able to break the cycle and try to reduce that kind of identity threat that results in high-risk behavior. I mean, silicone, people are using silicone for a whole bunch of different reasons, but one of the reasons is they don't have access to gender-affirming care. They can't get hormones. They can't easily get surgery, 3-year wait list, or they don't have insurance or whatever. So then the option is, for that very strong desire to affirm your gender physically, is to go with injected silicone. So what are the goals of hormone therapy? Well, for feminizing hormone therapy, it's the development of feminine secondary sex characteristics and suppression of masculine secondary sex characteristics. So the physical effects, it does all of these things. I think people are probably familiar with what estrogen would do. Some other effects, reduced libido and erectile function. This is important because some trans women, especially those who are doing survival sex work, need to retain their erectile function in order to make money. And another thing that hasn't been looked at all is if you have limited erectile function and you're using a condom, does that interfere with condom's effectiveness? A lot of trans women are insertive partners, especially with when they're engaging in sex work. A lot of sex work customers are looking for insertive penile sex. And then, I put this up here because it is true that hormones do interact with your kind of emotional and behavioral self. But I really caution folks to stay away from stereotypes that estrogen makes you moody or testosterone makes you angry. Stereotypes are rooted in some background of truth somewhere, but there's so much overlap in the Venn diagrams. And I hate to kind of put these seeds into people's minds, and I think it just kind of perpetuates a lot. The feminist in me starts to get very oh, that's just perpetuating stereotypes. And I think that we really are just perpetuating them. So I try not to, and I think that the flip side of that is that transgender women may have a lot of things that are causing them to have a lot of behavioral and mood issues. And I'm hesitant to just say, oh, well, now that they're on estrogen, they become very emotional, because that's not really likely the case. The general approach is to use an estrogen plus an androgen blocker plus a progestogen. Sometimes use a progestogen. And so this table is in here. I think, we have guidelines. These are actually going to be published at our website. So the Center of Excellence for Transgender Health, I'll tell you about it at the end. But we have a set of primary care guidelines, which were written in 2011. They're about to be updated in the next month or two. There'll be a greatly expanded and updated set of guidelines. And this dosing table will be on there. But basically, it's anything, oral, injected, or transdermal estrogen. And getting into the details between the three is probably out of the scope of what we can talk about now. But you'll be able to go to our website in a couple of months and get more information. There's some theory that if you give the tablets sublingually rather than swallowing them, there's a potential to reduce the thromboembolic effect by avoiding the first pass metabolism. And then there's one study out there that suggests that subcutaneous estrogen injections are non-inferior to intramuscular, so that might allow the use of a smaller or less painful, less traumatizing needle. We titrate the dose upward. Upward titration of spironolactone maybe will limit orthostatic symptoms because it's a potassium-sparing diuretic, so they can get a lot of urine and they get really thirsty. And the goal really should be testosterone and estrogen levels in the female physiologic range for your particular lab. So I don't like to really state any levels because I've seen wide differences from lab to lab. But our consensus panel, do not recommend supraphysiologic estrogen levels. There's no evidence to support that. There's never been any research that says that giving people higher doses of estrogen than would as kind of similar age non-transgender women have any improved impact or improved outcomes, and it may increase risk. If you can't monitor levels or you're not comfortable interpreting levels, you can monitor for physical effects. The risk of that primarily is that somebody may be saying, I feel great and I'm looking great, but their testosterone may not be adequately suppressed. And the real key here is suppressing testosterone, less so than replacing estrogen, right? People with complete androgen insensitivity develop as phenotypical female. So you need very little estrogen. You just need to get rid of testosterone. And so if you don't know that what their T level is, the patient may feel fine, you think everything's going good, but maybe there's actually some more T blockade that can happen that would allow a little more breast growth or something. So that's the primary reason why I monitor T levels. I monitor estrogen levels mostly just to make sure they're not sky high. I tend to be more interested in the testosterone levels. Lab monitoring, the most important thing really is just to follow the renal function if they're on spironolactone. There's no evidence that monitoring lipids changes outcomes in transgender people. The statistically significant changes in hormones that you see with, in lipids that you see with hormone therapy is not clinically significant at all. So I did a study. I followed 17 trans women for 6 months after they started hormones, and their triglycerides went up by 28. which is not, it's statistically significant. The p-value was like 0.006 or something, but it doesn't really have any clinical impact. So, I try to avoid being like, oh, it's going to make your triglycerides go up. Well, it might make them go up a little bit, but not really in a clinical range. Again, I don't want to get too much into this because I want to make sure we have enough time to do everything, but I'm just letting you know this will be up on our website in about 2 months. The most important thing is really following their renal function and then not freaking out too much about lipids. Maybe checking a fasting glucose yearly. And then we talked about all of this. After people have a gonadectomy, there's really no need to lower the estrogen dose because you're not using estrogen to suppress testosterone. Testosterone should be being suppressed by spironolactone. So you're really replacing physiologic estrogen. So if you're replacing physiologic estrogen or you're replacing physiologic testosterone in a trans man, there wouldn't be any reason to lower the dose after gonadectomy. You're just going to put the person through some, kind of mini menopausal kind of symptoms. So I don't change anything except remove the anti-androgens after gonadectomy. So one thing that's really important, I think, that comes up is some of the labs that we monitor on patients are sex-specific, right? So like hemoglobin and hematocrit have like a sex-specific range, and creatinine has a sex-specific range. But for trans people, that's a little bit different because trans women retain, even though their muscle mass will drop to that of a kind of similarly built and aged female, non-transgender female, the number of muscle cells they have is still increased, and so that might result in a little bit more creatinine. So it might be alarming because you have a trans person who's on spironolactone and they're on tenofovir, and then their creatinine is coming back flagged as high. It's 1.16. But the cutoff for men at your lab is 1.29 or 1.2 or something. So you actually, it would be flagged as high if they've been registered as a female in the system. But then you say, well, wait a minute, they're a trans woman. I'm going to let their creatinine kind of leak up to the male kind of maximum. And I tend to, there's a little bit of subjective interpretation based on kind of their hormone milieu. How long have they been on hormones, and are their hormones in the physiologic range? And then I kind of come up with like my own on the fly, like, what do I think is an appropriate range? So I tend to let all of these things leak up to the upper limit of normal for men. If somebody is, their hemoglobin is 17.5 and they've been on estrogen for 10 years and they have had a gonadectomy, I might be thinking about other causes of erythrocytosis in that patient. But generally, we allow kind of a wider range for H and H. Okay, tobacco. So tobacco in the setting of any estrogen use is a risk factor for venous thromboembolism, but what happens if the patient is not willing to quit? So there's a harm reduction approach, right? So remember the benefits, we talked about all the benefits of hormone therapy, weighing those risks and benefits. Transdermal estrogen has been studied fairly extensively in the menopause literature. The Ester study, and then there was a meta-analysis that was released along with that. It's going back into the late 2000s by Marianne Canonico from France. And transdermal estrogen in an average risk population has been found to basically have a risk ratio of 1 for thromboembolic disease. So anybody who's at any risk for thromboembolic disease, I put them on transdermal estrogen. As we all know, it's really easy to say, oh, quit smoking, and it doesn't happen, right? Quit smoking, lose weight, eat less, sugar. The patient is just going to eventually stop coming to see you. Because they're going to say, every time I go to see Dr. Deutsch, I want to get my hormones. All she does is talk to me about these nicotine patches and all this stuff, So harm reduction, meet the patient where they are, and maybe after a year or two of establishing a rapport, they'll be like, oh, really? There's a gum I can try? And then maybe you'll get them to actually cut back on their tobacco use. There are no calculators and there is no data to guide any kind of risk-benefit analysis with respect to the use of aspirin for routine thromboembolic prophylaxis in transgender women. I see a lot of people who are just kind of like, I'm taking aspirin because my doctor told me I'm taking estrogen, I should take aspirin. But the risk of massive GI hemorrhage with routine aspirin use is non-trivial. And without having data to guide that risk-benefit discussion, I tend to not recommend it unless it's a person who's, if they're smoking and they're insisting on using oral estrogen or a high dose of an injected estrogen, then I might put them on aspirin. But I don't know that I would put like a routine smoking person on transdermal only estrogen. You know, the reality is a lot of patients don't like the patches, and a lot of them just demand the pills or they demand the injections, and so then I usually, in that case, I will put them on aspirin. Okay, pituitary adenoma. Are people checking prolactins? People hear about this? So there have been several cases reported of pituitary adenoma in transgender women. I have not checked a prolactin on any trans patient in about 3 years. The reason is because the Endocrine Society guidelines for the management of an incidentally found pituitary microadenoma is to do nothing. And the only time you do anything is when they develop symptoms. So if I was to check a prolactin on a patient who had no symptoms and I found it was elevated and then I did an MRI and then a whole to-do, the recommendation is still to do nothing. So it's a whole lot of nothing that doesn't change management. If the patient is, however, telling me that they're having galactorrhea, they're having vision changes, new headaches, weird smell issues, or something else that would make me suspect a pituitary problem, then I would check a prolactin for diagnostic purposes. But for screening purposes, I don't do it. And I also, you know, there are people who, you know, oh, well, there's case reports and people tell me I've found 4 pituitary prolactinomas in my practice. But the thing is that, you know, it's kind of like prostate cancer, right? Like, what if you had never done anything for those 4 patients who had, you know, transsphenoidal surgery? Maybe you just didn't even need to do it, right? So I don't even do it anymore. Patients with a history of cancer, I mean, an active estrogen-sensitive cancer is really the only absolute contraindication to estrogen therapy. We know that androgen deprivation is a mainstay of advanced prostate cancer. So with respect to something like prostate cancer, I mean, we don't know for sure what role estrogen plays in prostate cancer. Certainly, we don't even know what the deal is with screening for prostate cancer in non-transgender men of average risk. So it makes it even more complicated. You're not going to do a PSA anyway. And even if you do an exam, I mean, their prostates are all going to be atrophied. So, you know, there have been a couple of case reports. They probably all were people who had at least moderate to advanced undetected prostate cancer before they started hormones. It's probably what happened. So getting into one of the last topics. So venous thromboembolism. So as I mentioned before, the data from the menopause literature suggests no increased risk when transdermal estradiol is used. Oh, I want to tell you something else. We have a grant right now to develop training materials for Middle Eastern countries in local languages, slide sets. And this slide set, you were the first people to ever see this slide. Second people, I did a lecture at San Quentin last week, but you're the second people to see this slide set. This slide set is actually changing daily as we get the final. So actually the references are not in this slide set yet because the research associate who's working on this is actually doing the biblio today because we're changing it around. So what I actually can do if people can, posting online situation can wait about a week, I'll be able to get you a fully cited, properly bibliographied, but this is like actually changing daily. This is literally hot off the press slide set. So, and the slides I gave to San Quentin last week actually these have already been revised again. So the menopausal data on oral estrogen is mixed. It shows maybe a 4-fold increased risk. But if you think about it in a population of average risk, I mean, walking around on the street, 1 in 1,000 to 1 in 10,000, an absolute increased risk of 4 is still very low. And again, you're thinking about that risk benefit and the benefits that transgender people experience when they are given gender-affirming hormones. The use of a progestogen may mitigate the risk, or may modulate the risk. So first let me talk about progesterone. I don't have a strong opinion either way. There's no data to suggest that progesterone is of any benefit to gender-affirming care, that it increases breast development or hip development. There's no data to support that at all. It's all anecdotal. But the flip side is that in transgender women, so we're not talking about non-transgender women, we're not talking about cisgender women, but transgender women who have a different risk profile, we think the risk of breast cancer is very low. The use of progestogens is probably not harmful either. And there's actually some data that suggests that the type of progestogen is the biggest input into whether or not that progestogen increases like thromboembolic risk, for example. And so the medroxyprogesterone, which is the one you most likely use, is not in the norpregnine group, which has been demonstrated to confer an increased risk of up to 4 times. But then actually when they looked at the data in the Esther study and the post-Women's Health Initiative data, and they looked at medroxyprogesterone, that subgroup of people did not confer an increased risk of thromboembolism. We talked about the sublingual route. And then the last thing I want to say, equine estrogen, so Premarin. I don't use that with my patients. You know, it comes from horses that are kept pregnant, and then they get their urine. They have a catheter, and then they extract their urinary estrogens. You know, some patients are using this because they've been on it for years. There's not really any evidence that one is better than the other. This is a patented drug, and so they've gotten onto certain formularies, and that's kind of the reason that it's out there. It's the hormone that was implicated in all the problems in the Women's Health Initiative. We think it has a slight increased risk of thrombosis and slightly inflammatory, hence the increased cardiovascular risk. You know, remember the Women's Health Initiative, which was the big study that made everybody stop taking their menopausal estrogens, used that. It used equine estrogens. It did not use human estrogen. So I don't know that, you know, that's why that data is not necessarily applicable to people who are taking bioidentical human estrogen. So where does this fear of risk of blood clots in transgender women come from? We'll be done in just a minute or two here. Studies from about 10, 15 years ago showed 20 to 40-fold increased risk of thromboembolism in transgender women. They were taking 200 micrograms a day of ethinyl estradiol, and they did not control for tobacco use. These were a bunch of European transgender women. These people were like born with a cigarette in their mouth, right? I mean, everybody in Europe smokes, and then you're trans, so that's an additional predictor of smoking. So like 200 micrograms a day, how much ethinyl estradiol is in low estrogen? 20 micrograms, right? So they're taking 10 times the amount of estrogen that's in like a current modern oral contraceptive preparation. No wonder they're all getting clots. And ethinyl estradiol is a known prothrombotic agent, whereas bioidentical estradiol, which is in like estrace and injected estrogen and estrogen patches, is not. So, and they actually, this Dutch sample that they have been following for years, the most recent publication is that there has not been an increased risk when they switched over to using 17-beta estradiol. So there's really insufficient evidence to guide the use of estrogen therapy, anticoagulation, or antiplatelet therapy in transgender women with risk factors or personal history of DVT. There's a few different scenarios. I kind of want to stop and go to questions here and just point you to these different scenarios, which will be on our website in the next month or two. But we have 5 different pathways that have been kind of proposed by our consensus panel that put together the guidelines. So we have approach to management of estrogens in patients with a personal history of DVT, approach to management of estrogen in patients with a family history of DVT, but they don't have a DVT themselves in the past, approach to a patient using oral or injected estrogen at the time of their first diagnosis. So this is somebody who's on maybe a riskier estrogen at the time of their first diagnosis of DVT. This is the approach to someone who is using a low risk, so transdermal estrogen at the time of first diagnosis of DVT. And then this is basically somebody who is anticoagulated and they're taking transdermal estrogen and they have a DVT. So I'm going to just kind of go to questions now. I'll leave you with some resources. And again, our protocol, our guidelines will be updated in about 2 months. They should be live, and I'll show you where to go for them. All this stuff will be there. There might be a couple of changes to what you're seeing today because we're still in a final review with our consensus panel. Some common surgeries at transgender people. These are different surgeries that people undergo. I'm going to skip going through the different criteria. You can easily look those up at the WPATH website. This is a model for perioperative care navigation that I propose that will be published shortly in the Journal of Healthcare Poor and Underserved that talks about ways in which we can prepare transgender people for surgery, help do assessments. Do they have do they have housing? Do they have healthcare literacy to understand how to take care of themselves? And then continue to do that reassessment while they're on a waiting list, because people can be on a waiting list for a year and their housing can change. Who's going to take them to recover? Who's going to help you get bandages? Does the patient understand like basic instructions for self-care, because now that we have Medi-Cal covering surgeries, we have a much larger demographic of patients who are low functional status, lower health literacy. And so we're actually implementing this model at UCSF Medical Center for our patients undergoing gender-affirming surgeries. So WPATH says it's unethical to deny surgery hormones on the basis of HIV status, and there really aren't any significant interactions. And then let me just leave you with these resources. And I'm sorry we kind of had to blow through this. I wanted to get to as many topics as possible. The Dimensions Clinic at Castro Mission Health Center, where I am actually the physician there, and we see LGBT youth under age 26. Alliance Health Project is a great resource for transgender mental health in the city. They're in the Medi-Cal system. I see patients at Women's Health Primary Care at UCSF, which is part of our Center of Excellence for Transgender Health affiliated clinic. Tom Waddell has many decades of providing trans care to patients. Lyon Martin Health Services also a long history of providing trans mental health and medical care in the city. API Wellness is now they're a federally qualified health center, and they have a ton of trans care programs that are going there. Royce Lynn is kind of the point person there. And then we have our PrEP project, which will be launching in the East Bay and Sacramento, and then DPH's arm of it will be here in the city. These are the current guidelines at the Center of Excellence for Transgender Health. These are some of the topics. You can go to transhealth.ucsf.edu, and it's there. And you'll see some updated guidelines in the next couple of months. So thank you very much for your attention, and I'd love to answer your questions. I know we're kind of tight on time, but thank you.
What do you think about GnRH antagonists and agonists, especially for people who are intolerant of spironolactone?
Yeah, so the question was, what about the use of GnRH analogs who are intolerant for spironolactone? It's a great option if you can get it covered. They're used commonly in trans youth, and the Child and Adolescent Gender Center at UCSF, Steve Rosenthal, pediatric endocrinologist, uses them all the time. It's a standard of care for transgender youth for delaying puberty. For adults, it's a totally viable option. It's been studied in Europe. It's expensive. And it's fussy, too. You either have to insert an implant, or they need to do 3 times a day nasal injections, or they need to do monthly injections. So it requires some infrastructure, who's going to do the implant, but it is a good option. Another option is orchiectomy. If the patient is interested in it, making sure that those kinds of procedures are available to patients who want them, it's a great and, kind of permanent and very effective way to block testosterone.
What are you recommending in terms of mammograms for transgender?
It's a great question. The short answer is, so our guidelines come out of a consensus process that involves a national panel of experts from community and academic backgrounds, MDs, nurse practitioners, physician assistants, a whole bunch of different people involved. And looking at the available evidence, which is almost zero, our panel recommendation is that once someone reaches the age of 50 and they have been on hormones for a minimum of 5 years, or have a minimum of 5 years of lifetime estrogen exposure, then it is time to consider to begin breast cancer screening. So we're using the most professional society guidelines in this country are using 50 as a starting age now. So we're defaulting to that more kind of, I guess you would call it liberal start time. And then we're saying that you need to have at least 5 years of estrogen exposure. It's not the most evidence-based recommendation, but we had to recommend something. And as we all know, there are significant risks of overscreening, especially when you have a test that has a high false positive rate, and you have a population where the prevalence of the disease is pretty low, especially someone who's only been on hormones for a couple of years. Your positive predictive value is very poor. So we don't want to wind up having all these trans women going for all of these invasive biopsies when the hit rate is likely to be very low. It's a great question.
Maddie, thank you so very much.
Thank you all. Thank you.